Hi, good morning, everyone. I'm Hatem Alansari, one of the fifth-year cardiology fellows at St. Mike's. And today I'll be presenting post-myocardial infarction mechanical complication and its echo findings. So I have no disclosures, and these are my objectives. So for today's presentation, I'll be discussing the epidemiology and incidence of acute MI mechanical complications. Then I'll discuss the risk factors for acute MI mechanical complication, and then we'll have a review of differential diagnosis for unstable acute MI patients. And lastly, we'll do specific case reviews for different conditions and its echocardiographic findings. So yeah, I was showing you this extensive review of the mechanical complication of MI. And in terms of this table here, it shows the all the possible complications and the pathophysiology and the natural progression for them. So broadly speaking, I'm not going to go specifically into it, but broadly speaking, there are electrical complications and mechanical complication. And the usual pathway into developing mechanical complication includes transmural infarction and tissue necrosis, with an end result of having myocardial tissue damage, necrosis, that can lead to septal wall rupture, free wall rupture, valvular pathologies, and an end result of cardiogenic shock. So in here you can see the epidemiology and incidence of mechanical complications of MI. And if you look in the graph down here, in the main categories or areas of the mechanical complication can be categorized into the pre-reperfusion era and the post-reperfusion era. So with the introduction of fibrinolytic therapy, the incidence have decreased dramatically. And it might have increased slightly in the primary PCI era, probably because of improved recognition and diagnosis of these conditions. But it has decreased again significantly since the introduction of systemic changes and care for STEMI patient and introduction of algorithms. So the current incidence is estimated to be around 3 in every 1,000 acute MI patients. And on the table on the right here, you can see each disease entity and its incidence in the pre-perfusion era and the reperfusion era, where you can see a uniform decrease in all of the complication here, a very significant decrease in the incidence. Interestingly, the mortality rates have not really changed since then, which is it still remains high, around 50%. And this is because these conditions are fatal, and even with appropriate surgical care, they still remain highly morbid, and the death rate is high. In terms of risk factor for these complications, they basically can be tracked to 3 main mechanisms: the size and the location of the infarction, the timing of reperfusion, and myocardial ischemic conditioning. So for patients with first MI presentation or single vessel occlusion, they have higher risk for developing these complications just because they lack collateral flows and their ischemic burden is high. Late presentation with presence of Q waves or patient with low socioeconomic status and poor access to PCI have higher risk. The location of the infarction is important, where anterior MI and proximal LAD lesions are also associated with higher risk. There are other patients factors, which includes age, more than 70, female patients, other comorbidities, chronic kidney disease, diabetes, hypertension. All of these have been associated with higher risk. But as you can see from the table on the right, that lack of revascularization have the highest risk of developing any of these changes, which correlates with the previous incidence and epidemiology of pre-reperfusion and reperfusion era incidence. So in the next 2 slides, I'll quickly go through how to approach a patient with unstable acute MI. And from this table here, again, you can see that unstable patients that we see in the CICU usually present with cardiogenic shock, probably LV, severe LV systolic dysfunction, and this diagnosis is important to be made early because of the mortality rate of this condition, the importance of introduction of early mechanical circulatory supports, and it's important to have good bedside skills in terms of physical examination and echocardiogram to make sure that none of these complications are present. So you can start treatment with vasopressors, inotropes, and you can refer patients for more advanced mechanical circulatory devices. Again, RV shock is very important. Usually the clinical diagnosis at the bedside is hard to make because all of these patients present very sick, but with good skills in echocardiogram and recognize this condition promptly. I think one condition that is very important, and it's mostly seen in the MSICU with patients with that hyperdynamic LV and intracavitary obstruction, whereas echocardiogram skills are very important because it will shift the management dramatically, where you're going to stop using inotropes and start using fluids. And just to keep in mind, there are other conditions that can mimic acute MI, and the diagnosis can also be made with good bedside echo skills. So acute PE, cardiac tamponade, aortic dissection. I think we saw a recent case of a patient presenting with a stroke, and the first diagnosis of aortic dissection was made by echocardiogram. So having good quality images, having a high clinical suspicion for these non-cardiac causes in unstable patients is very important, and can be made at the bedside. The diagnosis can be made at the bedside. So the main focus of my presentation is to talk about these four conditions: papillary muscle rupture, ventricular septal rupture, pseudoaneurysm, and free wall rupture. I'll talk about each specific case in my presentation, but before doing so, these complications share common features, and all of them have bimodal peaks, which means that they usually happen in the first 24 hours, and then the risk is high again in day 3 to 5. As I mentioned, having good clinical skills at the bedside, which raises your clinical suspicion for these conditions, and you can make the diagnosis clinically, but having bedside echo confirms the diagnosis and can help you make an early referral, which improves survival. And these are surgical emergencies, so if when possible, these patients should be referred to a surgical center, and the surgical teams should be informed and involved early on. With right now, the main goal of treatment is to involve a multidisciplinary shock team to have a discussion about the possible treatment options, which also include palliative care. Introduction of such teams improve outcome, improve communication, especially in the current era where we have mechanical circulatory support and ECMO. Bridge from these therapies to surgery can improve surgical mortality rates, as it allows for reperfusion, revascularization, and better tissue healing to improve the surgical outcomes. So now I'm just gonna go through each specific case. I'll start with my cases with a quick clinical scenario. You can basically respond to these questions through using this username, text, or join the website. I'll just give it 2 minutes until I have some responses, and we'll continue the presentation. Okay, perfect. So I have some responses. Yeah, so basically most of you got it right. The answer is RV infarction. As you can see here, this is a patient presenting with inferior STEMI, have clear lungs field, but high JVP, and his blood pressure, he went into shock after receiving nitroglycerin. This is a SATE-MIC case I got from the Black Book, which you can look here just from the parasternal lung axis, the RV dilatation, and you can see here from the RV inflow the hypo or akinesis of the RV inferior wall with the tricuspid regurg. And from the apical view, it's very dramatic. I'm just gonna, sorry, this is on loop. You can see the RV function, systolic function is severely reduced. The IVC is not clearly seen, but it's dilated and not collapsible. So I'm just going to repeat it again. So yeah, so you can focus here on the RV systolic function, especially in the apical view, where it's very marked severe RV dysfunction. And you can see here TAPSE, severely reduced, S velocity, again, severely reduced. All of these features suggest severe RV ischemia and infarction. So just to give you a few key points about RV infarction, it's seen about in 1/3 of inferior MI. Usually it's usually because of proximal RCA ischemia, proximal to the RV marginal branches. And the ECG, as you can see here on the right, present with inferior ST elevations. The classical teaching said lead 3 elevation more than lead 2 with the ST deviation and lead V1 and V2, and having right-sided lead would increase your sensitivity and specificity for the diagnosis. And the triad for this presentation is usually hypertension, high JVP, and clear lung fields. Usually also they present with excess vagal tone and bradycardia. And interestingly, the hemodynamics, they look like pericardial disease with rapid diastolic RV filling and steep right atrial pressure wide descent. The mortality rate is higher in terms of inferior MI if it has RV involvement. We don't really have good data recently, but previously in the pre-reperfusion era, the mortality in RV myocardial infarction reaches up to 30% compared to inferior MI without RV involvement. And the cardiogenic shock due to RV infarction still has a very high mortality rate, very similar to the LV cardiogenic shock rate. From this table, you can see different RV echo parameters that can predict RCA ischemia, RV ischemia, and proximal RCA lesions. And the most commonly known is having TAPSE less than 16, has very high sensitivity and specificity in patients presenting with MI to suggest that these patients have RV failure or RV ischemia. I'm just going to continue for the sake of the time and to discuss the second case. And you can join again with texting your answers, please. Yeah, so got some feedback back. So basically, the answers are split between septal rupture and papillary muscle rupture. So in this specific case, you can see that this patient is presenting with inferior MI again, and they quickly went into shock with significant pulmonary edema needing intubation. You can see from the physical examination, they don't really have a murmur, and this points towards having papillary muscle rupture in acute MR, which basically means that the left ventricle and the left atrium pressures are equilibrating, and this is why you don't really hear a murmur, in contrast to VSRs. And this is a case, this one is actually not to say it's my case, I got it from elsewhere, but you can see that there is a posterior medial, the posterior medial pap muscle is ruptured, and there is an acute, there's a severe MR with the eccentric jet. So I'm just gonna repeat the loop again. So a very interesting finding. If you find it, it means that these patients are really sick, and usually it presents very dramatically. So again, just to give a few key points, the severity of the MR usually depends on the degree of the pap muscle rupture, as it could be complete or partial if it involved only the cordia. The posterior medial pap muscle is the most commonly ruptured, just because it's supplied by one coronary vessel, either the RCA or CIRC. And the presentation is usually with respiratory distress, pulmonary edema. More than 70% of patients require mechanical ventilations, and usually because of the a loss of pressure gradient and equalization of LV and LA pressures, you don't really hear a murmur. The mortality rate is high; it reaches up to 40%. And just to go quickly through the management, so after resuscitation and diuresis, these patients should receive after load reduction if the blood pressure permits. Balloon pump to bridge until surgery is indicated in this case, and even in patients who are eligible for surgery, the mortality rate remains high. However, compared to medical therapies, surgery is the way to go to improve their survival. And in the shock trial, only 38% of patients have underwent surgery, mainly because these patients are really sick and they decompensate quickly, so they don't have enough time to be surgical candidates. The usual surgical technique is mitral valve replacement with a mechanical valve, because this have been tried and the outcomes are well known. And as you can see here in this picture, having from A, you can see the papillary muscle rupture. The surgical technique include mitral leaflet debridement and then implantation of the mitral valve. Pap muscle repair is an option, but outcomes are worse, and the results are less predictable, especially when the tissue is ischemic. In high surgical risk patients, there are reports of using mitral clip. However, all of these are case reports, and there's selection bias in these cases. So there is no standard of treatment in terms of less invasive strategies. So surgical treatment still remains the gold standard here. This is a different case. So if we say that our patient actually had similar presentation, but with less respiratory distress and a harsh murmur heard, you can see this echo here. So you can see the basal septum, and when you put color on it, you can see a left to right Doppler flow. This suggests that there is a basal inferior ventricular septal wall rupture, and you can see that usually with contrast, you can also have better visualization of the septal rupture and measure the size of the lesion. So again, a few key points. It's currently considered to be the most common of all of these four mechanical complications. The perforation itself can be simple or complex, so depends on the size and the location of the infarction, and it's usually associated more with anterior MI and apical septal ruptures. But in contrast, our case, and from the picture here, you can see that this is a more of a basal inferior rupture, and it's usually associated with a worse prognosis than apical ruptures. The presentation is usually with biventricular failure, and as I said, the exam is usually prominent with a harsh systolic murmur and presence of S3, and the mortality rate is considered to be higher, but still reaches up to 40% compared to pap muscle rupture. And in terms of management, the goal of treatment, again, is after load reduction to reduce the left to right shunt. In the shock trial, 75% of patients had a balloon pump inserted, and you can see that the systolic blood pressure mean have increased significantly from 81 to 102. So balloon pump is a temporary measure that would bridge to surgery, usually allowing more time for tissue healing and reperfusion means better surgical outcomes because usually in the acute phase the tissue is necrosed, and there's the surgeon have very hard time for suturing. So allowing a few days, especially with the balloon pump or other mechanical circulatory support, if these patients are stable, would means better outcomes. And you can see here that the surgical mortality rate is up to 40% when these repairs are done in an urgent basis. The usual surgical technique is Dr. Tyrone David technique, which usually exclude the infarcted tissue with a vertical incision made over the scar, and a patch is sutured over the healthy myocardium. There are less invasive technique, percutaneous technique, with a device, plug device that can be done in high surgical risk patient. However, these are less predictable than the surgical repair, and they're associated with higher risk of device failure and high risk of complication, including device embolization. So here you can see the third case. I'll just give you a few minutes to read it and give me answers, if you don't mind. Yeah, so again, all of you got it right. So this patient had a inferior lateral STEMI, had thrombolysis after 3 hours of chest pain, and then she decompensate, probably has a cardiac arrest, and you can't really hear any heart sounds, and the diagnosis is ventricular wall rupture. And this is a very dramatic case if you look into the echocardiogram, where from the get-go you can see the inferior wall and is akinetic, and you can see the flow. In contrast, I'm just going to repeat it again. Yeah, so you can see here there is an effusion. The inferior wall is akinetic, and you can see the bidirectional flow by the color Doppler and the contrast images. So actually, this patient survived and went for urgent surgical repair. This presentation is consistent with ventricular wall rupture. The reason why this patient survived is probably the rupture was contained by the pericardium, and usually this is a fatal condition that leads to cardiac tamponade and pulseless electrical activity. The reason why this patient would survive is either there is a thrombus that would plug the rupture, or the development of a false lumen or a pseudo aneurysm that would be contained by the pericardium. And this condition, in our case, it was inferior wall. However, the anterior wall is most commonly affected. And the use of fibrinolytic, it's usually associated with higher risk. As I mentioned, if these patients survive, they would present with shock, cardiac tamponade. They would have worsening chest pain just because of the tear and pericarditic irritation. Sometimes these conditions can be asymptomatic, and pseudoaneurysm can be discovered incidentally, where the differentiation between an aneurysm and pseudoaneurysm is basically made by the pseudoaneurysm shape, where it has a narrow base. It doesn't really have any wall into it. It's mostly a blood collection contained by the pericardium. And these pseudoaneurysms have really high risk of rupture, with 45% risk of sudden rupture at any given point. And the mortality rate is high, so these should be treated surgically. And in the acute phase, early recognition is very important to refer for surgical interventions. Bridging with ECMO is possible if these patients survive. And just a caveat that with the cardiac tamponade and the hemopericardium, these patients would also require pericardiocentesis to improve their ECMO blood flow. Even with surgical repair, the in-hospital mortality remains very, very high. And in this situation where the pseudoaneurysm is discovered incidentally and it's chronic, they still need surgical repair. And however, the surgical mortality rate is less. So mainly the surgical risk is high, mainly in acute phase. Usually this is repaired by either a patch repair or sutured or non-sutured. And here you can see, usually this diagnosis is made by echo, but if these patients are stable enough, they can get other imaging modalities. And here you can see a cardiac MRI. Over here in the big arrow, you can see the left atrium. There is a mechanical mitral valve and the left ventricle. And you can see here in the inferior wall, there is this huge connection between the LV and the pericardium with a blood-filled cavity and a jet that's more visible, the hypodense jet that's going into the pseudoaneurysm. The second picture here shows that this patient received a patch repair, sorry, this was a percutaneous plug, and this patient survived. And this is case number 4. I'll allow some time for the answers to come back. Yeah, so again, all of you got it right. So this patient is an outpatient and had a anterior MI 3 weeks ago, doing fine, asymptomatic. However, his ECG does shows persistent ST elevations. This presentation is more consistent with an LV aneurysm. And this is an unusual case, again, from the Black Book, where you can see the anterior wall hypokinesis. And when you start injecting contrast, you can see here that there is this, there's this diverticula, which the location is a bit unusual. It's in the anterior septal wall, but the outpouching is large, and it's more obvious here in the short axis cuts. So this presentation is basically consistent with an LV aneurysm, and in contrast to the pseudoaneurysm, this is myocardial tissue. It's usually scar tissue, and it's most commonly involved the anterior apical wall. The segments are either akinetic or dyskinetic, and depending on the size of aneurysm, this patient can present with several symptoms, including angina, heart failure, thrombus formation, and arrhythmias. The reason why these patients develop angina is because of the high end-diastolic pressure, as these diverticula act as a extra reservoir for fluid and blood. So the LV end-diastolic pressure increases, and it kind of acts like aortic insufficiency, where these patients have decreased coronary perfusion pressure, chronic volume overload, and can present with angina or heart failure. The physical exam, usually it's with a displaced apex and a systolic to and fro murmur. They can have S3 if they develop heart failure. They can develop also functional MR with the LV dilatation. As with our case, the ECG shows ST elevation that are persistent in a asymptomatic patient. So this is suggestive of an apical aneurysm. Other imaging modality provide better diagnosis and visualization of the aneurysm itself. And these are benign. They rarely rupture just because the actual layers are fibrosed. So and in contrast to the actual pseudoaneurysm, these usually have a wider base and they have very low risk for rupture. So as these aneurysms are usually discovered incidentally, survival is more than 90% in 5 years, and medical therapy is completely appropriate. Usually they're treated with afterload reduction agents, ACE inhibitors, just to manage their heart failure. And in the acute phase, in absence of thrombus, clinician could consider starting anticoagulation in high-risk patients. However, there is no clear indication to treat with the anticoagulation in chronic aneurysms. So in the absence of thrombosis or other indication for anticoagulation, you don't really have to treat them with blood thinners. An indication for surgical repair would include refractory heart failure, angina, thought to be related to the aneurysm and unresponsive to medical therapy, ventricular arrhythmias, and development of thrombus despite anticoagulation therapy. And this is my last case for today. Just gonna give you a few minutes to give me answers. Yeah, so again, you got the answer right. This is a patient who have a anterior semi severe LV dysfunction, akinetic apex, presenting with a new stroke. The diagnosis is consistent with LV thrombus. So this is a case from St. Mike's again, and you can focus on the severe LV dysfunction with anterior wall and apical akinesis. And from the non-contrast imaging, you can appreciate there is a density in the apex that is not really filling with contrast here. So this is consistent with LV apical thrombus. And I have another case here, and it's from a different patient, but it represents a more chronic thrombus, where if you look here in the short axis apical views and the four chamber views, there is a layered or a more sessile hyperdensity with filling defect, and this is a clue of a more chronic or a mural thrombus that develop in these cases. LV thrombus, which is usually associated with anterior MI, LV dysfunction with reduced EF, and anterior apical aneurysms. And the incidence is estimated now to be around 4% for all MI patients. However, with the MRI, the incidence can reach up to 8%, just because it has higher sensitivity and specificity compared to echo. The echo sensitivity can be between 25 to 35%, but can improve up to 60 to 70% if used with contrast. But however, the cardiac MRI still remains the gold standard. And the usual mechanism in developing LV thrombosis is the virtual triad, where stasis, endothelial injury, and hypercoagulability after MI leads to thrombus formation. And this process may take up to 2 weeks to develop. So it's very important that these patients have a echocardiogram in the first 48 hours after their MI presentation, and their echo should be repeated again, and if negative, in 2 weeks, and these echocardiograms should be done enhanced by contrast. They can be asymptomatic, but if they thrombose and embolize, can present catastrophically with a stroke. Even with anticoagulation, the risk of stroke remains high, 3%, and even higher in patients who are non-compliant or not appropriately anticoagulated, that can reach up to 19%. And there are some echo features that can predict the risk of embolization, where acute strokes have acute thrombus have higher risk. Mobile lesions, protuberant lesions have higher risk of embolization. And the second case that I showed you, the chronic thrombi with neural or sessile shape, have lower risk of embolization. And I'm not going to really go extensively into this for the time's sake, but this is an algorithm that is suggested by the AHA to assess for LV thrombus. They recommend having an echo with contrast in the first 24 hours. If there is no thrombus formation, but they still have high-risk features with the apical akinesis or dyskinesis, in patients who have an apical aneurysm or they can't really visualize the apex, they recommend repeating an echo again with contrast. And if the study still remains negative, they should still receive an echo after 2 weeks. And if the results are inconclusive, going to the gold standard cardiac MRI would be appropriate. If at any given point these patients have a thrombus formation, they should be started on anticoagulation, and the usual gold standard right now, or standard of care, would be treatment with warfarin. However, off-label use of DOACs is still being prescribed, but there are no large randomized trial to compare warfarin to other oral anticoagulation therapies. The treatment should remain at least, with anticoagulation, should remain at least for 3 months, with repeating an echo after that to document clearance of the thrombus. If there is still thrombus after 3 months, longer treatment is indicated. So I think this is my presentation for today. Thank you for listening, and hopefully you learned something. Happy to respond.
So thank you, Hatem, for putting together this very comprehensive review of mechanical complication of myocardial infarction. So I think despite some of the initial technical challenges went very well, and also have some degree of audience participation. So thanks everyone for joining. Can you comment on the use of POCUS in earlier diagnosis of mechanical complication? Do you come across any of these during your review?
Yeah, so the main source I used was a statement issued by the AHA regarding mechanical complication of acute MI, and they do mention the importance of having bedside echo skills and point-of-care ultrasound. From my readings, I haven't seen anything specifically related to mechanical complication diagnosis, like improving the diagnosis or outcomes if we use POCUS. However, like I'm aware of other situations where POCUS can improve diagnosis and outcome, but they do mention it in the AHA statement.
Yeah, I think from my experience of having to deal with patients with shock, in the critical care situation, often physical exam is very, very deceiving, right? So you have like papillary muscle rupture, but because it's so acute, the MR often is not like torrential because it's just very, very acute, and so on and so forth. Sometimes the new murmur of ventricular septal rupture could be very confusing with MR versus going across the ventricular septum, and last but not least, the ventricular septal, pseudoaneurysm is almost impossible to figure out on physical exam. So, having an early echo when someone is coming in with myocardial infarction is probably could be one of the standard of care, because physical exam is somewhat limited in the things that we can see. So, especially now, POCUS is so pervasive and widely available these days. So I think it could be actually written in as like you do a history, physical exam, your ECG, your biomarkers, and then it will be POCUS. That's what I'm thinking.
Yeah, exactly.
Almost becomes standard of care. Any other comments? So just before I go there, so I would strongly encourage you all when you're admitting patients to critical care or CCU, do a POCUS on them. I think, and include that in actually your admission review, because that would be part of the extension of the physical exam, so as to say. Okay, good. So any other questions? Then other colleagues of mine to ask questions or comments. If not, I've got one more. So the question is actually the looking of thrombus of LV. You mentioned about the presence of LV aneurysm, and then starting to look for the thrombus. Obviously, we would do contrast to increase the sensitivity of us looking for them. My question is the frequency, because right now we actually do not do that often. So often patients with anterior myocardial infarction, large anterior MI, or even big heart attack, we would do the echo often initially upon admission, and then we would probably do them between 1 to 3 days after they've been admitted. But we don't usually do this 2 weeks follow-up. because it's hard to bring the patient back so quickly. What do you think about that in terms of like practical implementation of that?
Yeah, I think it all depends on the, like, I haven't really seen, because this is, I think, a practice that is more widely done in the US, and this is the AHA statement from there. So I'm not really, I haven't really looked into the incidence in different practices, as even if you discover these thrombi after 2 weeks and the clinical significance, because I'm sure like there are some sort of thrombus formation and risk, especially with the acute MI period. So yes, I guess it can increase the incidence and the diagnosis of LV thrombus, but like the actual clinical outcomes and starting treatment with anticoagulation, would it be significant enough? And this is another question of like, should we use cardiac MRI post-MI patients just to increase our sensitivity of detecting these thrombi? So I think this is a very interesting area to look for and see if outcomes would be different if we do change practice.
Just a quick follow-up question. I remember at some point in the history of cardiology, we used to actually anticoagulate everyone who has a large anterior MI, so as to say, right? That was one of the exam questions. And now, what is the current practice? Should we anticoagulate everyone with a large MI, or should we anticoagulate everyone with a large aneurysm that we see in echo? What is the current recommendation for that?
Yeah. So they do mention this specifically, prophylactic use of anticoagulation in high-risk patients. So high-risk patient, as you mentioned, large anterior MI, severe LV dysfunction, apical aneurysms, and the AHA guidelines basically say that this is 2C practice. So they don't really recommend it, but they do mention that it's still widely used, and a lot of centers do prescribe anticoagulation for these high-risk patients. So it's a common practice to prescribe these anticoagulation in high-risk patients, but it's not really recommended by the AHA guidelines.
Yeah, that's one of the practice change, I think, because in part because we vascularize them so early now compared with the old days. And we used to use thrombolysis, right? That was in the dinosaur years, but now we actually can do like a primary PCR on most of them. So salvage of the myocardium is much more than ever before in history. So I think in part the shift of learning over the years, because that's what we learned when we grew up, but now I think the practice has changed. So any other questions? It's coming out to 9 o'clock.
I thought I saw Kim pop into the images. I'm not sure if he had a question.
Yeah.
Yeah, thanks. I was sort of going to ask a similar question to what Qiming asked about the routine anticoagulation. And I think it just gets back to the point that mechanical complications are seen far less now because of the the rapid access to the cath lab. And we're much more likely to see that in populations who don't have early access or are late presenters. So it is much less frequent than what we used to see, where mechanical complications were much more common back in the day when people presented late with STEMI.
And even in the incidence, my first slide, you can see that most significant reduction in incidence was related to the LV thrombus. So I think it increased from in the pre-perfusion era, the incidence was estimated to be around like almost 60%, and now it's around 4 to 8%. So yeah, all of these interventions reduced it significantly.
So thank you so much, Hatem, for giving this presentation. It's one of the topics we haven't reviewed for a while, and so wish everyone a wonderful day, and we'll have it on the video archive so more people will access this. Thank you.